angiography head and neck. Clinical info. Dizziness and whistling sound in head, more on left, for 2 years. CHTN, asthma and chronic atrial fibrillation since long. Technique. 0.625 mm reconstructed images from a scan performed on multi-slice CT scan, reviewed on workstation using different window and level settings. Post-contrast CT angiogram head and neck is performed according to departmental protocol. Findings. Mild atherosclerotic changes with calcified atherosclerotic plaques are seen in arch of aorta and at ostia of its major branches without any significant narrowing. Aortic arch branches have normal anatomy. Right carotid system. There are mild atherosclerotic changes in right common carotid artery, CCA, with small eccentric calcified and non-calcified atherosclerotic plaques. However, CCA is normal in caliber, well opacified and patent. Dense atherosclerotic plaques are seen in CCA bulb with extension in proximal ICA and ECA. The plaque is causing mild narrowing of CCA bulb. It is extending in proximal 7 mm long segment of ICA and is causing 41% luminal narrowing according to NASCET criteria. Rest of cervical ICA is normal in caliber, well opacified and patent, is mildly tortuous. Petrous, cavernous and supraclinoid ICA are patent. Small calcified atherosclerotic plaques are seen in cavernous and supraclinoid ICA causing mild luminal narrowing. Right MCA, ACA and their branches are normal in size, well opacified and patent. ECA and its branches are normal. Left carotid system. Mild atherosclerotic changes with small calcified atherosclerotic plaques are seen in left CCA and CCA bulb without any significant luminal stenosis. Cervical and petrous ICA is normal in caliber and shows few tiny eccentric calcified plaques without any definite narrowing. Distal cervical ICA tortuous at the point of entrance in carotid canal at base of skull and is abutting internal jugular vein. Mild to moderate atherosclerotic changes with dense calcified atherosclerotic plaques are seen in left cavernous and supraclinoid ICA. ICA bifurcation, ACA, MCA and their branches are well opacified and patent. ECA and its branches are normal. Vertebrobasilar system. Small calcified atherosclerotic plaques are seen in bilateral vertebral arteries, pronounced in their intracranial part, causing mild luminal narrowing. Right vertebral artery is relatively hypoplastic and left one is dominant. Bilateral pica, AICA, basilar artery, superior cerebellar and posterior cerebral arteries are well opacified and patent. CT venogram. Superior sagittal, transverse, sigmoid and straight sinuses are patent. Internal jugular veins, vein of Galen, cortical and internal cerebral veins are normal. Bilateral cavernous sinuses show symmetrical and adequate contrast opacification. Bilateral superior ophthalmic veins are not dilated and appear patent. There is no evidence of dural sinus thrombosis or AV fistula. Bilateral jugular bulbs are normal. There is no evidence of high-riding jugular bulb or dehiscence of sigmoid plate. No evidence of glomus jugulare, tympanicum is noted. Bilateral cavernous sinuses are well opacified and patent. Bilateral superior ophthalmic veins are patent. However, left superior ophthalmic vein is relatively prominent in caliber. Left cavernous sinus is relatively small with prominent Meckel's cave. There is no evidence of cortico-cavernous fistula, dural AVM, AVF. Brain. Mild age-related cortical atrophy is seen with proportionately prominent extra-axial CSF spaces and ventricles. Cella is diffusely enlarged and partial empty. Bilateral Meckel's caves are mildly dilated. Rest of brain parenchyma remains unremarkable. PNS and mastoids. There is mild mucosal thickening in bilateral maxillary and ethmoid sinuses. Rest of the paranasal sinuses are clear. There is deviation of nasal septum towards right. Orbits, eyeballs and soft tissue at base of skull do not show any abnormality. Bilateral mastoid air cells are clear. Bilateral middle and inner ear structures, including internal auditory canals, cochlea, semicircular canals and auditory ossicles are intact. External auditory canals are clear. Bilateral tympanic membranes and scutum are intact. In neck soft tissues, multinodular goiter is seen with bulky thyroid having multiple calcified and non-calcified nodules in its both lobes. Prominent but sub-centimeter level 2 cervical lymph nodes are seen. There is no definite lymphadenopathy. Parotid and submandibular glands do not show any abnormality. Visualized lung apices show mild congestion. Age-related degenerative changes are seen in visualized osseous structures. There is no aggressive osseous lesion. Impression. Mild atherosclerotic changes in arch of aorta and its major branches including bilateral carotid and vertebral systems, with multifocal small calcified eccentric plaques, pronounced in right CCA bulb and proximal ICA causing 41% proximal ICA stenosis according to NASCET criteria. No evidence of dural AVM, AVF, carotico-cavernous fistula, glomus tumor on base of skull, high-riding jugular bulb, dehiscence of sigmoid plate or aberrant ICA. Mild age-related cortical atrophy. Changes of idiopathic intracranial hypertension with diffusely enlarged partial empty sella and prominent Meckel's caves. Correlation with fundoscopy is recommended to rule out papilledema. Sinus mucosal disease, multinodular goiter, atherosclerotic disease of ICA and idiopathic intracranial hypertension both are among the common causes of tinnitus in this age group. Correlate clinically.